All right. Hello, everybody. Good morning, good afternoon, good evening, wherever and whenever you're joining us from today. Welcome to another episode of the Coach's Corner. Woohoo! Today's episode is going to be really cool. It is a definitive guide to macular degeneration. And I'm really excited about our guest. He is amazing. He is a pioneer in the low vision community. He has spoken at so many different events and lectures and been on the radio. He's amazing. And he's one of my good friends and mentors, Mr. Tom Persky. Hi, Tom.
Hello, good to see you almost, as we say in the low vision world.
Yes, yes, for sure.
It's great,
So
great to be here and great to be with you and look forward to our time together today.
yes, I understand you have a little bit of a sound clip you want to play for us.
Alexa, continue. I don't know if you can hear that. Alexa, volume 6. There we go. When I was in Chicago, I did a radio show for every Saturday for 8 years. It was about living with low vision. And this
Mhm.
was my theme song.
Nice. It's a little tough to tell which song it is. Can you tell us which song it is?
Alexa, pause. It's called Better Days by
Ah,
Pat Donahue and Butch Thompson. Kind of a folk song and kind of a folksy, like sit on the front porch and in your rocking chair kind of a song.
very cool. Well, thank you for that. Awesome. So Tom, today we're going to talk about macular degeneration, which is a subject that I know that you're very knowledgeable about. So we're excited about that. To jump things off, can you just kind of give those of us who maybe don't know too much about macular degeneration, if we know anything at all, just a quick little like definition of what macular degeneration is?
Sure, sure. You know, I've been working in the field of low vision for over almost 40 years and have worked with many patients over the years in helping them improve their functional vision and using technology. But I often talk about macular degeneration in sort of a down-to-earth way. And
Okay.
so I'm not a medical doctor, of course. And so, but I'm going to describe it the way that I describe to people. And I'm going to use some medical terms. If you want to take notes, I think it might actually be helpful for you because one of the things I like to do is have people, when they're getting treatment or they're seeing a specialist, I always recommend they see somebody, a retina specialist,
Mhm.
that they get a letter each time that you go to the doctor. And what that letter should have in it is very important. And I'm going to go over that today. But, you know, macular degeneration is the leading cause of vision loss around the world. In developing countries, as many as 1 in 5 over 70 is developing macular degeneration, about 1 in 4 over 80. So if you look at a chart of the incidence of like hearing loss as you get older, and that macular degeneration is almost the same curve. And of course, people know about hearing aids, but they're not as well versed in vision aids and devices. So we'll talk about that also later. But it's a disease of the central portion of the retina. And so the macula is kind of the most important, the cells that are giving you 20/20 vision.
Mhm.
If there's any news, the entire retina, which is like the movie screen of the eye, remains intact. So you do have, 90, 95% of your vision that's never affected by macular degeneration. So that's a little bit of a good news. But the
Yeah.
bad news is, over time, you can lose, starting with the center where you see fine detail and you see faces and all the things we have to do for driving and things like that. That's the part that's going to be affected. And we'll talk more about the macula being that central portion of the retina. I myself have a juvenile form of the disease and been living with macular degeneration since I was in college, with a disease called Stargardt macular dystrophy. So mine was a autosomal recessive gene from both sides of my family that caused it. And we know a lot about genetics now also, that macular degeneration, there are 5 or 6 genes that cause it. Primarily people also, there's some risk factors, fair skin, lighter colored eyes, where you're exposed to ultraviolet light, persons who are outside a lot in their younger years, maybe didn't wear sunglasses, maybe you're at the beach, maybe you were a farmer. All these sort of risk factors play into the beginning stages of macular degeneration. The number one risk factor, though, they say, is too many birthdays. And so we'll talk about that.
So is macular degeneration necessarily hereditary then, or not?
Yeah, yes,
Okay.
yes, yeah, yeah. It seems more and more evidence that it does run in families, and there's more gene studies being done and for the future clinical trials to try to do what they call gene therapy
Okay.
and some of those. So, but yeah, too many birthdays we mentioned, fair skin, lighter colored eyes, um, exposure to ultraviolet. One of the ones I always throw in there is with my Polish background is too much kielbasa, which basically refers to nutritional things that we think maybe some people have not have had a poor diet or have not been able to take certain nutrients. For instance, dark leafy green vegetables, we hear about that. Spinach and kale have what are called carotenoids, lutein, that is very important for your eyes, for your lungs. And so we'll talk about that a little bit too. So these are some of the things that have been looked at and studied over the years.
Oh, okay. And are there several different kinds of macular degeneration for those of us who don't know? Is there just one type? I know that, well, two types, because I know there's dry and wet, right? But is it more than just dry and wet macular degeneration?
Um, yes, that's the common phrases that you'll hear. Years ago when I was diagnosed, they told me there was juvenile macular degeneration and senile macular degeneration. And
Okay.
that's actually what they called it. And so
Wow.
maybe the doctor got slapped after telling the patient she was senile. So now, of course, it's called age-related macular degeneration, AMD for short. And that's right. When persons, here's where I want to get into some of the description and what things you should know and what questions you should ask. So, persons who develop the very early onset of macular degeneration, in fact, maybe even before it affects the central vision, when the doctor looks in the eye, he can look at the entire retina, and sometimes you will see little accumulation of waste products that look like little yellow dots, and they're called drusen, drusen. So drusen can start and be there for a long time before your vision, your macula starts to be impaired. So for instance, when the doctor's got looking in your eye, you could say, "Hey doc, is there any drusen back there?" Or, last time I came here, you didn't tell me I had drusen, but I'd really like to know, are there more drusen now in my eye this time than there was last time? As the accumulation of these waste products um, uh, interfere with what the metabolism is in the retina. That's one sign that things are getting worse. Also, those drusen are small at first, and if they start to clump together and they become large drusen, you want to say, "Hey doc, do I have any large drusen?" That's a sign that it's really getting worse. And sometimes at the beginning stages, as the light comes in your eye, comes through the pupil, through the lens, and it hits the surface of the retina. The surface looks like, under a microscope, it looks like bristles of a hairbrush.
Oh,
And those are called photoreceptor cells, and they're like little antennas that catch the light. So sometimes the beginning of macular degeneration, and this is what I'm describing is the dry form, is when they look in your eye. Think of the center like a bullseye, and you've got all the rings of the target, right? So the macula is just the bullseye area right in the center. It looks like a bald spot is developing. That is, those little bristles are starting to fall out of the brush. And one of the things I like to explain to people is, think of it like a pie with 8 slices. Some people have the beginnings of the dry form. They may have one slice of the pie missing. So they might look at a word like baker. They see B-A-K, but they might not see the E-R. Or some people see K-E-R, but they don't see the B-A, depending on where the slice of the pie is missing. So if you only have one slice of the pie, you can probably do pretty well. You could probably still drive, maybe read large print books with reading glasses and so forth. But it's a slow progression where you begin to lose more slices of the pie, 2 or 3 or 4 slices of the pie. And then if you have a that's more moderate phase of the disease, until you finally reach what we call the end stage. And that end stage is called geographic atrophy. And you might have heard GA for short. And basically what that means is all 8 slices of the pie are now missing. So your macula is at the end stage. It's not going to go into your peripheral vision, and you're not going to go blind, like they
okay,
say on TV.
right.
And so, yeah, so that dry form is, like I said, slow progressing, little by little. And so when you go to the doctor, you want to know what is what they call vision acuity measurement. That is, on the eye chart, how did I do? What was the vision in my right eye? What was the vision? Let's say it was 20/50. What's the vision measurement in my left eye? And you want that in the report that you're going to ask for at the end of every session. Because what happens is the doctors might say, your vision is about the same as it was last year.
Mhm.
But when you pull out your own reports, you say, wow, my vision was 20/50 this year, and now it's 20/60. That means it's slightly worse. So there's a way for you to know by having your own reports. And on the report, it's going to say OD. OD means right eye, 20/50. OS means left eye, 20/60. And they call that BCVA, best corrected, meaning with your glasses or your contacts on, best corrected vision acuity measurement. And so you say, Doc, I want to know what my acuity measurement is. Please put that in my report. So here's a summary of some of the things that you want on your report. You want to say, what was the appearance of the retina? Was there drusen and so forth? What was the appearance of the macula? Okay, so what did it look like? Did it look, like it's starting to get worse? And then what was the vision acuity measurement? And then if you want to put them to the test, of course, if you're getting treatment, you want to know what treatment am I receiving? And I'll talk about the wet form in a minute because there's injections, different drugs, and most people are getting injections. They don't know what they're being injected with. And there's some new drugs that are out there now that you want to ask your doctor about and whether you're a candidate for these new injections. And then finally, at the very end, you say, I want to know the prognosis. How bad is it going to get? What does it look like? And the doctors, sometimes they're reluctant, or you might be reluctant to want to know.
Yeah.
But they can sort of tell scientifically, they've seen enough patients where they can tell you what they think is going to happen the next year or 2 years or 5 years. And so all of that information should be in your letter and ask for, I know that people nowadays have all that information in their medical portal and you have to go in but I just say no, please print that
Right.
out for me, right?
I
And
know I'm
because
one of those people. I don't like the medical portal thing. I like to either have it in my hand or speak to a human, right? And I know a lot of us who are partially sighted feel that way because the portal can be confusing sometimes. So
right,
that's great.
right,
It's great. Like you're saying, ask for a printout.
exactly. And if you really want to shock them, ask for it in large print, and of course they
Imagine
would they
asking
would
for it in Braille.
and they wouldn't know what to do if you asked them for that. But um, so the progression of macular degeneration, about 20 to 30% of people who have this, progression of the dry form, that's the surface of the retina. We're now going to talk about the wet form, which is actually sort of behind the retina. And this, like when you cut your finger and your body brings the blood vessels to the surface to form a scar so that you don't bleed to death. We
Hmm.
think it's a similar thing that there are, it's called vascular endothelial factor. Anyway, it causes the eye to maybe try to heal itself. And what happens, I call it like the weeds growing underneath the sidewalk, is these new vessels, the doctors call it neovascularization, which just basically means new vessels, start to grow behind the retina. These new vessels are weak. The walls of the vessels can leak fluid and they leak blood sometimes.
Hmm.
And so you've got a couple problems there. You've got vessels growing and you've got some moisture, and your retina is sitting in moisture, which is not good. Your retina is very thin. It'd be like having Kleenex on the table, but there's a little wet spot, and the Kleenex doesn't like sitting in a wet spot.
Right.
And so new injections, I call them like the weed, I call it the weed killer, because basically what they're doing is they're squirting that underneath the retina. And guess what happens? All those vessels shrink and go away. And it's actually dries up anything that's moist back there. And that's a good thing because if they catch it early, then um, you've saved any severe problems from happening. Um, but guess what? Just like the weeds, they grow back again, and
Ah,
then you have to go back for another injection, all right? And then the weeds go away, and then they grow back again. And so that's why people have to go, and the doctors can tell, how often you need treatment for the wet form. So that should be in your report too. What are they injecting and how often, what treatments are recommended? And if you're not 100% satisfied with how things are going for you, you can always, it's your eyes, so you can always get a second opinion or a
Right.
third opinion. You sort of have to have a bulldog personality sometimes. It's the
Yes.
patient, and just say, I want to know, I want another opinion or whatever. And if you've got all your information in your file, you can sort of take that with you if you did that. That information is really helpful too if you later decide to go to a low vision optometrist for low vision service, and they like to know the most up-to-date information about your medical treatment and so forth. So the doctors are supposed to give you a Amsler grid, right? This is the grid that has a lot of squares on it with the little button in the middle, but
Okay.
they don't have enough time to explain
Right.
what you're really supposed to do with this grid.
Right.
So
They're like,
this is
here
a
you go.
very
Take this home and read the instructions that you probably can't see. Right.
right.
So luckily
So the
we have
grid,
you to show us how to use that.
yeah, the grid is very important to your monitoring your own vision. And what you do would hold that grid up, and you're going to be testing one eye at a time. Okay. So many of us with macular degeneration, they look at the grid, and I ask people, point to where you see distortions already. And they say, oh, it's right here. I can show you it's all messed up right in the middle. The rest of the squares look pretty good. And then we test the other eye, and they show me where it's distortions. People at the early stages might not have almost no distortion, but what happens over time is, remember I said the vessels start and they grow from the side or from the top
Right.
or from the bottom of the retina, and they're growing towards the center. So what you're really trying to do with the Amsler grid is you're trying to monitor, is there any new squiggly lines that weren't there before?
Right.
And squiggly lines are a sign of neovascularization is starting, and they're usually coming in from the top or the bottom or the side going towards the macula. If that happens and you see a new squiggly line that wasn't there before, that actually could be an emergency. It could mean that the new vessels are growing, the wet form is activating itself, and you need to get in right away. And they say, well, we don't have any appointments for 2.5 months. You say, no, I'm going to drive over today because I saw new squiggly lines on my Amsler grid. So again, you have to be a little bit of a bulldog personality, to be able to make sure that you don't go a long period of time, especially maybe 2 days in a row. It looks like, wow, I really know that that's a new area. So don't throw the grid away, because after 6 months, it looks really boring. You're doing the same test, nothing changes, and people get tired of doing it. But I'm telling you, it could be a year from now or 2 years from now. You could wake up one day and look at that grid and say, wow, now yesterday it was fine. Today I can see there's changes. So you never know when those changes will occur. And so it's very important that you keep monitoring your vision. And while you're doing that, you could also ask the doctor. You could have, bringing yours, or have the one and have him explain it. But I think I explain it pretty well. And
Yeah. The only question I have, Tom, is when you're using the Amsler grid on your own at home, so you stick it on your fridge or put it on your wall in your office or wherever, maybe your bathroom mirror, how far should you have that grid set up? Is there a specific, like 5 feet,
well,
10 feet, specific distance?
yeah, it would be more like a normal reading distance, or you could use it with your reading glasses if you'd like. So 12 to 16 inches is probably for those of us with more severe macular, you might want to get a little bit closer
Mhm.
just to make sure. Yeah, and then don't forget, do one eye at a time. Yep,
One eye at a time. Okay. And probably what's really important to remember is to make sure you do it at the same distance each time, right?
that's correct. Yeah. But you'll be able to tell where you're. Some people even draw a little circle around their distortion today, like
Hmm.
here's what it looks like, and maybe they draw a circle around it, and then you know that anything else looks pretty straight. The lines look straight. Then if you see new squiggly lines, now you could actually do that. Also, let's say the blinds on the window, it could actually test it out. Some people say I'm driving down the road and all of a sudden the telephone pole looks like doesn't look straight anymore. That's
Uh,
almost like the same sign that something's changing. And there might be fluid or there might be new vessels growing underneath the retina. And so that's amenable to treatment now. And so there are injections that have been used now for quite some time.
mhm.
And many people get those once a month. So that becomes a trial to have to go to the doctor, have to get injections once a month.
Mhm.
So there are new injections. Uh, you might have seen on television. One is called Vabysmo. I think it's Vabysmo, Vabysmo. The idea of this new drug is that it's like a stronger weed killer. You don't have to go maybe every month, maybe you only have to go every 2 or 3 months. And so that would be a breakthrough. And it's a new treatment. Ask your doctor if you're a candidate and whether or not that would be important to you. The other thing you're going to hear on television a lot, as I mentioned before, is when they talk about GA. So GA, as we talked about earlier, is the end stage of the dry form. There was never been a treatment for the dry form. So there's millions and millions of people here in the US who have been living with the dry form. And the new drug or injection is for those with GA, those who are at the end stage. Now, that's not going to improve your vision. Um, some people are a little bit misled. Also, you want to read some of the side effects of this new injection because some people, they're required if something happens and you're in a clinical trial, you have a stroke or you all of a sudden have the wet form when you didn't have it before. Some of these things happen when you get an injection. And so you want to know the risk factors and you want to ask your doctor the risk factors. But basically, this new drug is known as Izervay is one, or Syfore. These, but just basically ask your doctor about, do I have GA and am I a candidate for this new drug? And it's so new now that some doctors are waiting a little bit to see how it's because it's just been approved by the FDA. But I think what it's doing is, remember I was saying it looks like a bald spot.
Mhm.
So the retina is sort of like a carpet that's worn, and underneath the carpet is the padding, right?
Right.
And the padding is a layer of tissue under the macula called the retinal pigment epithelial. In fact, it's called RPE for short. So I think this, I'm not sure, but I think this new drug is to support the underlying layer so that the macular hole or the blind spot doesn't get larger over time. And so that's an interesting way that I feel like I can say that that's what the purpose of that is. It's not to give you better vision, but it's to keep it from getting worse over time.
Okay. So sometimes I come across clients who, have lost quite a bit of sight. Is that typically because there may be an underlying condition other than macular degeneration usually? Because
Yeah,
I believe they seem to think that it's because of the macular degeneration.
that their severity of vision loss is greater, or is that
Yes,
what you mean?
that it's greater.
So,
Mhm.
of course, other eye conditions, right? People say, well, I'm tired of going to the doctor because they can't do anything else for me. And so they stop going. Well, you want to be able to at least go once a year or so, because you could have developed glaucoma, which would steal you of some of your side vision. That would be horrible. There are other things. They're called the retinal vein occlusion. Basically, the arteries or the veins can sometimes be occluded, and that could cause a severe loss of vision all at one time. And so being able to see your doctor and just keep up with that as much as they recommend. That's where the prognosis is important too, because he might say, in the past, I want to see you every 3 months or every 6 months. But if they think that you're kind of through with any activity, and they say now you don't need to see me for a year, okay, then that could be a sign that things are settling down. And then if you want to go forward with, let's say you haven't had your prescription glasses changed for a while, this is where low vision services come in, where somebody trained, especially in low vision, does what's called a low vision refraction for your test. Instead of going, how they used to go in the old days for 10 minutes, which is better, one or two, three or four, one or two, and they
Yes.
kind of rush you through. Well, low vision refraction is take their time. Sometimes it over an hour of service, where you're going to get the very best prescription possible. Now that's also a little controversial when I talk about that, because when you're at the early stages, your glasses, you think your glasses are going to help, right? And
Right.
the glasses have a curve to the front, and they bend the light rays so they touch the retina, but the retina has a hole in it now. So that's why normal glasses, or the doctor might say your retina, well, normal glasses won't help. And they're sort of correct when they say that, but they're sort of not correct. And here's where I think could be happen is the eye changes over time. So you go to a low vision refraction, and they say, well, your prescription has changed a little bit. And because it's very painstaking, they have to take their time to go through to get the right measurement. And okay, who wants 10% better vision? Okay. So the people at early stages of macular say, well, I know glasses are $400, or I know they're expensive, and they're only 10% better. Maybe I'll just forget it. Where I raise my hand and say, if you give me 10% better vision,
Yeah,
I will take it, right?
me
And
too.
so it's all on how you live with, and how long you live with, and whether but I urge everybody, consider going to a low vision specialist. an optometrist who's had training in that, because that's only one portion of what they do. Now there's telescopes that can be mounted on your glasses for things as I think there's over 30 states now that allow telescope
Right.
glasses for driving, actually.
Right.
And those are called bioptic telescopes. And so it's BIO. Bio means two. Bioptic means you can look through the bottom to see your prescription regular. You're driving and you're staying in the lane. But let's say you can't see the road sign way far down the road. You drop your chin, you look through the top. So that's two places that you keep your eyes. And you can't look through the top for a long period of time because it's a very narrow field of view. So you learn to go up and down to be able to see farther down the road. That's just one type of lens. In low
That's
vision,
pretty cool. Yeah, the
we
bioptic
talk
is
about
pretty cool. And
yeah,
just for
bioptic. You
yeah,
can
just
look up bioptic driving.
mhm.
Do a Google bioptic driving, and you'll be able to find information. Every state has a different law of how much whether you're a candidate or not.
Right, right. And just for those of you out there watching, I did do a Coach's Corner episode on bioptic driving specifically. So if you want to go to the YouTube channel, check out the Coach's Corner. You'll find the episode that I did specifically about bioptic driving.
Right, right. Um, there are a myriad of reading glasses. People go to Walgreens and they're trying to get a +2, and then they try to get a +3, and that's about as far as you can go. And in low vision, we start with +4, +6, +8. These also have prism in them, so you do have to hold things much closer. But reading glasses don't stop at 3, and so you should know that. Um, I use a reading glass that's +24,
Oh
and
wow.
it's so close to my eye that I can't use both eyes at the same time. So my left eye is a little better than my right eye, and that's a whole nother subject we could talk about when you can't use two eyes together anymore, because your brain, when you have normal vision, your brain's trying to make one picture, right, out of two eyes that are similar. But when you have one eye that's worse than the other, your brain keeps trying to make one picture. And I was working with a lady the other day, and she was looking through her right eye with a magnifying glass. And she said, I can only read 3 lines down on this little reading card. And I said, okay, now let's hold this over here by the left eye. Oh my gosh, I could read all the way to the bottom. And
Nice.
that's how different her eyes were. We sat and talked for a while, and then I said, about 10 minutes later, let's review what we did before. And guess what? She picked up the magnifying glass, and guess what she did, right? She put it over here by the right eye again. I said, remember what we just did? Oh yes, oh that's right. So here's part of what we call vision rehabilitation, is learning not just about magnifying lenses, but where to hold it, which eye to use. There's a lot of training involved in helping people, and that's what you're going to get if you go to a good low vision center.
That's awesome. And
So
then
that's very important.
there's
Then,
also
then I was going to mention, Iris Vision has been a big help to me since it came out over what, 5-6 years ago now. And the new 2.0 version, I have it right here with me. It is a pair of you say goggles like, or gargle like, that is using the smartphone and a camera. So technology in a camera can do a lot more in some ways than a lens can do. for instance, a camera can be automatic focus. So you could read up close and then you could turn and see across the room. You could go to a concert or a play because the camera makes things brighter. When I went to Europe last summer, we're in these churches, that are 800 years old and as dark as could be. You put on the Iris Vision, boom, everything's super bright.
Nice.
And it turned like somebody turned the lights on. And then
That's
we
cool.
were on a river boat and I'm standing on the top of the river boat. And normally I couldn't see anything on the side of the river, but with the Iris Vision, I was able to see like the little villages as we went by. I could see people walking or riding their bicycles. And people were looking at me like, what is that guy doing? And
They
you have
usually
to
think you're
stop
playing a
and
game, right?
you have to stop and explain, oh, these are magnifying glasses. I said, you know how people have used magnifying glasses over the years? And they say, yeah. I said, well, this is, my $3,000 magnifying glass that helps me in every situation. And they're, oh, okay, and then they sort of kind of go on. But there are, in the low vision, there are also apps that work well with a smartphone. I'm a big proponent of using Apple products because Apple has uh, both now. The Seeing AI is the app that everybody loves. It's now on Android also. Seeing AI is the little camera that will actually take the characters that it's looking at and read it out loud to you. I mean, what could be better than that, right?
Yeah,
Um, I,
pretty
re-
cool.
I remember meeting Ray Kurzweil, who was the developer of what's called optical character recognition back in our low vision conference in 1993. And he brought this machine out on the stage that looked like a small washing machine. And he lifted the lid and put a book in and pushed the button. And we had to wait about a minute or two. And then it started reading out loud, and we all, oh my God. And I know he sold those machines to the library. I think it was $35,000, that machine. But
Wow.
he promised that in 25 years he would have a machine that you could put in your pocket that would read out loud, and it would be less than $1,000. And of course, we have that today with well, as long as you have a smartphone, you can use Seeing AI, and it's free. And just this my whole career. I've seen this happen with so much technology, whether it's the computer, your iPad, and now reads out loud. You can dictate with Siri. You can ask Siri what's the temperature, what's the forecast. If you're in a restaurant, you ask Siri, what's 15% of $84.32, and all those good things. And that's just made life so much easier in so many ways. And those who are a little bit afraid of the smartphone, find somebody that can help you with learning to do everything. You learning to text or learning to make phone calls with just with your voice, and
Right.
that's pretty cool. Yeah.
It is. It's very cool. And there's so much out there. Again, like you mentioned earlier, Tom, we could totally have another one of these webinars and dive a little deeper into some of these other things that people can do just to help with their daily living, right? Just things that they could do around their home. We can dive a little deeper into the nutrition, right? And maybe some of these other devices that are out there during another webinar. But this has been really amazing. And there are so many advancements in technology, so many advancements in medicine. Um, as we learned yesterday, or at least I learned yesterday, you can go to a website called clinicaltrial.gov, and that's for here in the United States, clinicaltrial.gov, and you can look up all of the different trials that have been completed or are currently in process, active, or that physicians are actually recruiting for from that website if you're interested, clinicaltrials.gov. And
GOV, right?
yes, sir.
And I just want to warn people that if you ever have to, they say, pay for a clinical trial, stay away from those because
Yes,
there's funding, lots of funding from our government and private sources that are doing really good research, and there's no need to be being sucked into something where you have to pay for it.
absolutely. Absolutely.
Yep.
And for those of you who want to learn a little bit more about Iris Vision, and if you're a good fit for our device, you can always reach out to our awesome sales team via email or phone call. You could email sales@irisvision.com. That's SALES at irisvision.com. Or you can call in. The phone number is 855-207-6665. You could reach out via social media. Lots of different ways you can contact us to get more information about Iris Vision and to find out if you're a good fit. If you're a current user of Iris Vision, you can still reach out. You can call into customer support, or you can email support@irisvision.com if you have any questions. If you need a refresher on your coaching or anything like that, you could reach out and we can definitely get you set up as well. Answer any questions you have. We have an awesome sales team and an awesome support team that is always here to help you out with anything you need. So again, Tom, thank you so very much for joining me on this really awesome, informative episode of the Coach's Corner. Again, I feel like there's a part 2 coming in the future for this particular topic. So we'll look forward to chatting with you again.
Look forward to it, Myrna, and I always enjoy doing this together and helping people understand and be a good advocate for yourself, be a good communicator. And if you're not getting what you need, please keep seeking it out. They're your eyeballs, as I always say. And it's important that you get the help that you need.
Absolutely. And I heard a really awesome quote, and this is going to be helpful for people who are maybe experiencing sight loss right now and don't know what to do. It was actually from that summit that we attended yesterday, Tom, and it was, blindness is not a curse, it's just a new beginning. So keep that in mind as you're going through your journey of sight loss, and stay tuned for more informational webinars from our end. And again, thank you so much, Tom, and we'll see you guys next time. All
Take
right.
care now. Okay.
Bye-bye.